but I'm going to start the webinar. So what I'll do is take you through some of our mandatory informations to start with, and then I will let Andrew introduce himself before I begin my talk. Like I said, I am Helena Haptiastris. I'm a clinical academic nurse in diabetes and chronic kidney disease. So today's webinar is a non-promotional webinar organized and sponsored by Pfizer. The slides have been reviewed for medical accuracy and compliance with ABPI Code of Practice. This webinar and presentation is intended for educational purposes and is not intended to replace clinical advice from any of your health professionals and healthcare team. The views and opinions expressed in this presentation and webinars are of those of the speakers and do not necessarily reflect the views and opinions of Pfizer. So these are our disclosures, and I'll leave that here for a moment. And then what I'll do is I'll perhaps just give the floor to Andrew to introduce himself, and I'll take you through the agenda. Andrew, take it away.
Thanks ever so much for inviting me to come along and talk about my journey. And I look forward to giving you a background on that. Over back to Helena.
Thank you. So the agenda for today's meeting, I will begin by providing you an overview of CKD or chronic kidney disease and COVID-19, drawing on the current evidence in this area and highlighting the health inequalities faced by people with CKD. I'll then discuss when to test for COVID-19 and how to actually obtain this lateral flow test. Followed by the review of preventative measures and self-care consideration for patients with CKD. After my presentation, I will hand over to Andrew Freeman, who will share his lived experience of diabetes, chronic kidney disease during the COVID-19 pandemic, and including the clinical challenges that he faced. Once we finish with Andrew's presentation, we'll then open the session for questions and discussion. We would like this session to be as interactive as possible, so if you have any questions, please feel free to put them on the chat, and we will try our best to address all the questions. With a caveat that obviously this is an educational presentation, so I would not be able to address individual medical advices, but I will strongly suggest that if you have individual queries in relation to your medication or health inquiries, do seek advice from your healthcare professionals. Thank you, and I will now proceed with the presentation. Okay, so let's start by really looking at basic background information about COVID. So COVID-19 is an infectious disease caused by SARS-CoV-2 virus. The symptoms typically develop 2 to 14 days after exposure. The virus can mutate, producing different version known as variant. And the World Health Organization classifies this as variant of interest, being monitored for potential change in behavior, variant under monitoring requiring further evaluation, and variant of concern known to affect transmission, severity, or immunity. At present, COVID-19 is regarded as an endemic and it continues to circulate, but we are learning to live with it and manage its impact. And I think it's particularly of interest as we go into the winter months. So COVID-19 symptoms can range from no symptom to all to severe illnesses. They're commonly classified into 4 categories. Asymptomatic, meaning no typical or atypical symptom, but individuals can still carry and transmit the virus. The mild symptoms include fever, dry cough, sore throat, runny nose, sneezing, fatigue, muscle ache, headache, and loss of smell. And these are generally manageable at home. Moderate is characterized by high fever above a temperature of 37.8 degrees Celsius and persistent dry cough and sometimes wheezing, and patient may require close monitoring for this. In the case of severe, it involves complications such as difficulty in breathing, shortness of breath, confusion, chest pain, loss of speech or mobility, and these cases often require an urgent medical attention or hospital admission. So if you have the severe symptoms, obviously it's very important that you actually seek immediate medical attention. So the key point here is symptoms may vary with new COVID-19 variant and can also differ depending on vaccination status. The risk factor for serious illness from COVID-19. So this slide highlights the key groups at a higher risk of developing serious illnesses if they contract COVID-19. So these groups are people with underlying health conditions such as diabetes, heart disease, lung disease, HIV, or cancer. Advanced chronic kidney disease, patients with CKD stages 4 and 5 are especially vulnerable. Individuals on kidney replacement therapy or dialysis, their immune system and overall health may make them more susceptible to COVID-19. Organ transplant recipients, those taking immunosuppressant medication to prevent rejection, are at significantly higher risk of severe outcomes. Therefore, the key message here is COVID-19 risk is not evenly distributed, and certain groups, particularly those with advanced kidney disease or immunosuppression, require extra vigilance. So what do I mean by severe outcome? And severe COVID-19 can lead to serious complications. Patients may become critically ill. They may require hospitalization or admission, or need mechanical ventilation to support their breathing, or some may require intensive care, and in most serious cases, it can result in death. So the key message here is recognizing this risk underscores the importance of prevention, vaccination, and close monitoring, especially for vulnerable groups such as people with advanced chronic kidney disease and those who are immunocompromised. So bear with me, I'm now going to talk to you about a study that looked at COVID in the context of diabetes and chronic kidney disease, that really to illustrate the burden and the problem of people actually having poor outcome from COVID-19 if you live with multiple long-term conditions. So this is a study, an English study done in the UK, led by Holman and group, which investigated the risk of COVID-19 related mortality or death in individuals with type 1 and type 2 diabetes in England. This is a large population-based cohort study, which included over 3 million individuals. And they used their data from the National Diabetes Audit, which is linked to the COVID mortality records. The analysis showed that a lower estimated glomerular filtration rate, which is your kidney measurements, and I'm sure many people on the call are aware of that. So that's the rate at which your kidneys filter the waste products from your body, was strongly associated with increased risk of mortality in both type 1 and type 2 diabetes patients, specifically if individuals with eGFR level below 60. So if anyone with a value of below 60 have higher mortality rate. I'll come to explain what those figures mean in a moment. So what we are looking at here is hazard of death or mortality. So essentially, hazard ratios are commonly used in survival analysis to really compare the risk of the outcome between groups. So a hazard ratio of 1 means there's no difference between groups. So there's no difference with someone whose EGFR is above 90 to someone whose EGFR is below 50. If the hazard ratio is greater than 1, that means there is a higher risk compared to a relative normal kidney function or a reference point. If the hazard ratio is less than 1, so this is the hazard ratio I'm referring to where you see my cursor, it means there's a lower risk in the compared group relative to the reference, which will be the normal estimated glomerular filtration rate or EGFR. For example, in people with type 2 diabetes and EGFR of 30, so we're looking at this particular column and this row here. So if the EGFR is less than 30, it's associated with hazard ratio of 2.31, indicating that individuals with severely reduced kidney function had more than double the risk of COVID-19 related death compared to those with normal kidney function. A similar trend was observed in the type 1 population. So this is the hazard ratio for type 1 population, and this is the hazard ratio for type 2 population. So a similar trend was observed in the type 1 diabetes population. Progressively lower EGFR values were associated with substantially increased hazard ratio, really highlighting the elevated risk of mortality in this group. So in summary, you can see if you had type 1 diabetes and your EGFR is less than 15, your risk of dying from COVID-19 is up to 8 times higher. So in summary, declining kidney function as measured by EGFR was a powerful predictor of COVID-19 mortality in both type 1 and type 2 diabetes, and the lower the EGFR, the higher the hazard ratio, therefore the greater the risk of death. I'm happy to answer any question around this study if it's not clear at this point, but I'm going to move us on to the next slide, which is really looking at what we've learned through the data over the last 5 years. So what we've learned about COVID-19 and kidney disease is that kidney disease as a risk factor. I think that's very clear from the study that I've showed you earlier on. So individuals with CKD are at a higher risk of severe COVID-19 symptoms and increased risk of mortality. This risk is particularly pronounced if patients are receiving kidney replacement therapy or if they're older. Ethnicity and infection severity is also one of the risk factors that's been identified. So many studies have now shown the difference in infection rate and severity based on ethnic background, with some groups more likely to require hospital admission. In terms of socio-economic factor, so CKD patients with COVID-19 often experience higher level of deprivation, which is associated with more severe infection, and increased deprivation has also been identified as a predictor of breakthrough infection following vaccination. So these are data that are publicly available and information that we've actually looked over for the last 5 years. I suppose the sort of the key message here is CKD patients face multiple overlapping risk factors for severe COVID-19. Okay, so another information or evidence that we were able to gather through the publications of data in this cohort is COVID-19 and CKD in terms of its challenge and lessons. So what we've learned is acute kidney injury, particularly hospitalized COVID-19 patients with pre-existing CKD were at a higher risk of acute kidney injury. In terms of long-term dysfunction, COVID-19 can accelerate the decline of kidney function, and particularly after hospitalization. In terms of mortality, CKD patients with COVID-19 experience higher mortality compared to the general population. Really, in summary, COVID-19 adversely affects both short and long-term kidney outcomes, encompassing the importance of close monitoring and proactive management in this vulnerable group. Okay, so now we've looked at the symptoms, we looked at risk factors. So what I would like us to consider at this point is actually, how do we identify COVID-19 early? So a lateral flow test, I'm sure many of you in the call are aware, and you can see the picture here. This is what it looks like. What it is it's a self-administered test that detects SARS-CoV-2 antigens, and it provides the results within 15 to 30 minutes. So the specific advice for high-risk group, particularly people with advanced CKD, is that we recommend that if you have any new symptoms such as fever, cough, sore throat, shortness of breath, please test. And particularly if you also are aware that you had a known exposure before dialysis session or prior to a hospital appointment. Let's say, for example, you went out with a friend for a meal, friend texted you over in the evening to say, look, I've just found out I've got COVID. I think it's a good point to test at that point to really make sure that you haven't got it, and also making sure that you're not going to spread the infection. Even if you didn't have the symptoms, it's a good idea to test. And also let your dialysis unit know. It doesn't mean you have to escape your dialysis session, but what it means is that the unit then can facilitate a safer session for you, as well as containing the infection or the spread of the infection. It's also especially important that dialysis units or transplant recipients get help in terms of actually where do you need to obtain this lateral flow test, and I'll come to that in the next slide. So before then, what I would really want you to take as a takeaway message here is regular use of lateral flow test in high-risk populations, such as people that live with kidney disease, helps to detect infection early, protects both patients and healthcare environments. So this slide is really a practical guide to how you can obtain your free lateral flow test. So not everybody is eligible. I have to say this because we've now got a guidance, a national guidance, who can get a free lateral flow test. So if you live with CKD stages 4 and 5, or have had kidney transplant or are on dialysis, you are eligible to access this lateral flow test. Access, however, can differ depending on where you live in the UK, and I'm really sorry about that. But what I will say is just you can see the guidance here. I've put the links in here. But the easiest thing to do probably is Google this information over, so you would know, and you can put in your address or your postcode, and it will tell you which pharmacy locally is available for you to get your lateral flow test from. So the key message here is high-risk individuals can access free lateral flow tests to monitor their COVID-19 status and reduce risk of spreading infection. Right, as the old saying goes, prevention is better than cure. So back to the basic hand hygiene. Regularly washing your hands helps reduce the virus spread, or as well as vaccination, staying up to date to protect against COVID-19 infection. And please do take up when you are offered to take your seasonal COVID and flu jabs, because they are going to keep you, protect you essentially. Masks, wear a protective mask if you're immunocompromised or in high risk settings. Or by that, what I mean is, it's a lot of crowd, you're going into that space, just make sure that you've got your mask on. And then I put at last, know your numbers and keep them in target. What I mean by that is keep your blood pressure, your glucose level, that's your blood sugar if you live with diabetes. I as well as your weight within the ideal range that you or target that you've set with your healthcare professionals. And other key health metrics such as your cholesterol level within target to support the overall immunity and reduce complications. So combining hygiene, vaccine, and protective measures and monitoring health metrics help CKD patients reduce their COVID-19 risk and maintain an overall health. So we've now come to the end of my talk. So to summarize what we've covered, so we covered symptoms and risk factors for COVID-19 with a particular focus for people that are living with chronic kidney disease or advanced chronic kidney disease. So people with advanced CKD and kidney transplant recipients remain at a higher risk of severe COVID-19. We have reviewed the evidence on how COVID-19 affects kidney patients. In terms of testing, we discussed the use of lateral flow tests for kidney patients, including when to test and how to access them. In terms of prevention, vaccination, hand hygiene, mask use, and keeping clinical targets such as blood pressure, blood glucose level, as well as your weight and cholesterol within a range that are key to reducing risk in this in the kidney population, and staying informed and following the latest NHS guidance on symptoms, testing, and prevention and management, I would say. So the key message is vigilance and prevention measures are essential to protect kidney patients from severe COVID outcome. Thank you. With that, I'm gonna unshare and hand the mic over to Andrew, who's going to talk us through his lived experience. And yeah, I'll hand over to you, Andrew, so you can take over. Thank you. Thanks for listening to me.
Excellent. Thank you. Good afternoon, everybody. My name's Andrew Freeman, and I'm here today to talk about my lived experience, my journey, really. So up until the age of around about 29, 30, I was normal. I was living my life as everybody else. And then over a period of around about 2 or 3 months, my body weight dropped by a third. I had an unquenchable thirst, which meant that I was going to the toilet an awful lot. And I was quickly diagnosed with type 1 diabetes. I didn't have any family history. I didn't have any weight issues. My pancreas simply stopped working. So obviously a bit of a shock. Lifestyle changes, change of diet, that kind of thing. But it was really like being a type 2, except I sort of crashed into this new fairly difficult lifestyle. And over the course of the next few years, I had different insulins and different regimes and things, and did my best to try and manage my bloods as if I could. Around about 2003, 2004, I went on a Daphne course, which is drug adjustment for normal eating. I think there's a parallel course now called Desmond as well, but I did Daphne, which was great because it helped you count your carbs and live a little bit normally. Unfortunately, carb counting, whilst is great, it's great if you know what your ratios are and what you should be taking when you should be taking it. So it can be a little bit hit or miss. And for me, I found that every time I had an incident, which would be, I don't know, broken arm, poor shoulder, every time I went to a medical professional, the first thing they said was, "Oh, but how's your diabetic control?" And I'm like, "Well, no, it's not. It's my arm, or it's my leg, or whatever." So it can be a little bit tiring. It would be easy to say that you could be the world's best diabetic, if that's all you did. But unfortunately, that's not all we do, is it? Because you have to work, we have our partners, we have a much wider scope of things that get in the way. So during 2011, I started to have some reflux, which meant that actually my carb counting became very difficult because I'd eat food, take the insulin accordingly, and then find that I actually couldn't keep it down, and then would go into huge amounts of hypos. So that became quite difficult, although I had my throat widened after some endoscopic procedures, which made life a little bit better. And I took some relaxant drugs that were prescribed, which made life easier, but it's very difficult to maintain a steady diet, eating, and still maintain my balance. This obviously went on over a number of years. I had some ups and downs. I was dehydrated, and I had an AKI injury, and ended up in the hospital, which was obviously not particularly great. It turned out that I then had Barrett's esophagus disease um, in my gastropipes, which was also a little bit upsetting. It's pre-cancerous, so at least that's something not to have to worry about at this precise moment. So we carried on, and we tried to look after our bloods. We tried to maintain our health and keep balanced control. However, annual review in 2017, I hadn't been feeling as great. I started to have um, sweats when I was eating sort of various foods, and I just thought it was something that's at the unusual. But I carried on living and continuing. Unfortunately, I started to sort of like get swollen ankles and things. I was like unsure. Anyway, um, I went along for my annual review, and they came back and said, "Oh, actually, Andrew, can you come back in 6 weeks?" So I thought, "Oh, it's a diabetic thing, right? Back in 6 weeks." So I rolled back in 6 weeks, and they said, "No, no, no, come back in another 6 weeks." So I'm like, "Okay." And they said, "Oh, Andrew, we need you to come and see our renal team." And I'm like, "Huh, okay, right, fine, renal team." So I popped along to the renal team, and they said, "Andrew, good, you've come in, dialysis." And I said, "Yeah, I know what it is." And they said, "No, no, no, you need it." And I'm like, "Well, when?" And they said, "Urgently," which was, as you can imagine, having been living with diabetes for nearly 20 years, to then being told that actually my kidneys were not working, and I was in shock, really. Um, Over the next 12 weeks, I was admitted for PD, home dialysis. Um, I had a loss of appetite. I had no energy. I started to become less cohesive. I was hallucinating. I had some Bell's palsy, which hit me really, really hard. Um, and I was in fast decline, and I really didn't understand it. My son was only a year and a half old. My wife was looking after him, trying to look after me because I was becoming incoherent, and was having to come along to my appointments to see that make sure that I didn't just sit there and say, "Oh no, I'm fine, I'm great, no, I'll do that, it's fine," because really I wasn't functioning properly. My blood pressure started to skyrocket, and then I also had postural drop, which was unfortunate um, as well. And during this course of decline, I got referred to a gentleman surgeon at Guy's Hospital by the name of Chris Callahan. And Chris Callahan said to me, "Andrew, you're 49, you're quite young. You need to manage your diabetes. You need to be as healthy as you can be. And if you can match those things, and we could find you a donor that matches perfectly, you could potentially have kidney and pancreas transplants." And I looked, and I was just in shock because I was unaware that such a thing actually existed. I said, "No, I can't have a kidney transplant because the list is really long, and I haven't got any siblings, and my parents are too old." They said, "No, no, no. Unfortunately, we'll take a mortality, but this could happen for you." Well, excuse me if I up a bit. Um, it became like a light bulb went on, and it gave me a focus, and all I looked at was trying to manage my diabetes and get myself healthy enough to join the transplant list. And on the third occasion, I was brought in, and I had kidney and pancreas transplant from a young man who sadly had lost his life. I found this out obviously much later, but his parents were incredibly brave, incredibly strong, that they managed to offer their sons organs for donation. And I was the incredibly lucky recipient of those organs. Um, Obviously, major transplant work is big. Um, I came out of obviously transplant good. Unfortunately, I then went into sepsis. We had 3 bouts of sepsis, which really, well, it wasn't pleasant. I finally left hospital in the October 19. Managed to pick up a slight foot injury via way of a blister, which I hadn't had during diabetes, but apparently losing a lot of body weight during dialysis meant that I picked up a foot ulcer, of which then I had a podiatry issue, and they talked about amputation, but that fortunately didn't happen. But we were at COVID, and so I was immunosuppressed, very highly immunosuppressed. So I had to basically be locked down for a considerable period of time, which obviously led me and an awful lot of people um, to the point of probably being quite pressed. I'd been self-funding since September 17, and unfortunately, I'd run out of money. So I reached out to our friends in government. But they told me, because I'd been self-employed from that point and not been very well, I hadn't paid enough national insurance. Therefore, I wasn't liable to any funding, which actually sent me on quite a poor um, mental health route, which weighed me down quite badly for a period of time, as you can imagine. Um, However, we finally become out through COVID, and I am better, and my feet are relatively better. And so I look to say, well, actually, why didn't I know anything about diabetes and CKD? I later find out that 40% of type 1 diabetics can end up with some kind of kidney disease. So I'm extremely passionate about raising awareness by having just having a urine test and a blood test and a pressure test once a year at your GP. It should be legally a quaff, but obviously that's not happening at the moment. And so I thought, right, what can I do? So now I spend my time supporting research into kidney disease, awareness of it to diabetic groups and to other people, and try and support people via peer support. So talk to people that may be on the journey. I can't clinically help you with that, but I can give you some support of having lived through an awful lot of this journey. So that's pretty much me. I'm very grateful to be here, and it's my onward mission to try and support others. It can be bad, but there is potentially light at the end of the tunnel. It's not the end of the world, but your health is in your hands. So I want to thank all the medical professionals that may see this, and all the people that have supported me throughout the journey. And let's say thanks ever so much, and open to any questions I can possibly help you with.
Andrew and Alina, thank you ever so much for your presentations. I think we've all learned something this evening, haven't we? We have got some questions on the chat. If I miss one of yours, it's not personal. It may be they can't answer them. Now, you talk about in your presentation avoiding COVID, and quite a few people have mentioned face masks and things like that. And they've also said about the work setting that if you work, nowadays it's the known thing, oh, you've only got COVID, you need to come into work. To people that have not got transplants or kidney disease. So how can we avoid them situations, and if you do have to work and mix with people that are coming into work with COVID?
That's a great question, Pete. It's really using things that are accessible to you. So if you're using a public transport and you know you're a high risk person, use the mask. Where you can social distance, try to probably isn't so much easier on a London Underground, or in some workplaces appreciate that. But applying really what you can to minimize your risk, then getting vaccinated would be key as we going into the winter. And then obviously, if you are somebody who's leaving with diabetes or chronic kidney disease or hypertension, just making sure that all of your parameters are within the clinical target that you've you are working towards to, and that you're able to achieve that, just so that you minimize your risk of poor outcome. And these are things that you can control. There are things that we cannot control, and we can't do anything about that. But what we can control, we should be able to control. And then flexibility with your employer. So are you allowed to have working remotely option? That's something that you can discuss with your employer, particularly if there is a peak and we're aware of it. Yeah, I think those are probably my kind of comments on this. Thank you.
This next one, interestingly, is from a doctor, and he's put, I'm not aware of the fact that high-risk patients can get lateral flow tests. So maybe we can just revisit talking about the lateral flow tests and how you can get them and things for kidney patients.
Yeah, thanks for that question. It is so the government has actually come up with a plan who's eligible to access the free lateral flow test. So you'll be aware during COVID, everyone was eligible to get them, not anymore. And this is based on very much the evidence. And if you have advanced CKD stages 4 and 5, and you're on dialysis or have received a kidney transplant, and your transplant has failed within the last year, so these are all eligible criteria. How you access them, however, is a bit of a nightmare and is very different depending on where you live in the country. So I showed a slide about links, but I suppose what the best thing to do is actually Google. And if you're England, how do I access lateral flow test NHS? And then you put your postcode in, and then it will tell you the nearest pharmacy that's going to be providing you with the lateral flow test. And of course, you can pay for these things, but if you are eligible, why not get the lateral flow test for free?
You talk about in your presentation the research program. Is there anywhere that people can find out more about this? And
Oh, absolutely.
is it still open as well?
Yeah, so the open safety data about COVID and CKD is Googleable, if that is such a term. You can Google that. You can also look at the UKKA, which is the UK Renal Registry and Association. They have a whole bunch of information on COVID and CKD. The kidney care has also got a whole bunch of helpful information. What to do if you got COVID-19, what are the treatment options, and they go in much more detail than what I describe here. So those are the helpful kind of sites I would say to look at.
Yeah, and us here at the National Kidney Federation, we've just updated our COVID page for all the latest information. So that's kidney.org.uk. If I haven't covered your question and you want a question answered, you can email us here at the National Kidney Federation. You've got our links. There's certain compliance rules tonight with the webinar that we can't answer all the questions regarding drugs and things. But thank you ever so much to Andrew and Alina for tonight's presentation. Thoroughly enjoyed it. I think it's been really useful, and especially after all this time when COVID was in the news constantly, and we never talk about it anymore unless you are in the kidney world. So thank you. It is being recorded, and you'll get an email of when it's going to be available for watch again through our YouTube channels. But for now, thank you very much, and look out for the next webinar, which I'm hoping is going to be about nutrition coming up to Christmas and dietary. So thank you.